Everyone. I'll be speaking on radiation segmentectomy for early hepatocellular carcinoma is curative. An evolving application of radiation segmentectomy for the treatment of hepatic malignancy. The purpose of radiation segmentectomy is to deliver high dose of radiation to targeted hepatic segments through yttrium-90 transarterial radioembolization, limiting the volume of normal hepatic parenchyma exposed to radiation. The radiation segmentectomy dose to achieve explant complete pathologic necrosis for glass microspheres is currently greater than 400 Gray in hepatocellular carcinoma, where outcomes have been comparable to accepted curative intent therapies like surgery and transplant and ablation. It shows a liver lesion treated with segmentectomy, and it shows complete response on follow-up. Conventional radioembolization is done via lobar or proper hepatic arteries. In case of radiation segmentectomy, it is different that a higher tissue ablative doses are delivered via segmental liver arteries and with sparing of the majority of liver tissue any radiation exposure. And it is usually recommended for single HCC tumors up to 8 centimeter of diameter. Radiation segmentectomy comes from two trials, RACER and LEGACY. This trial was a single center and single arm study. It enrolled 29 patients who were unfavorable for ablation and were followed up to 24 months. Among these patients, 90% had sustained complete response on follow-up. Morbidity was mainly grade 1 or 2, fatigue, nausea, vomiting, anorexia, abdominal discomfort, decreased blood counts, or raised LFT parameters. Grade 3 leukopenia was seen in 14% and grade 3 thrombocytopenia in 7%. There were 2 cases of grade 3 adverse events, 1 arterial injury and 1 ascites. The other trial was the LEGACY study. It is a multi-center study from 3 centers. It enrolled 162 patients with a tumor of 1 to 8 centimeter. The previous RACER study included up to 3 centimeter lesions. And the objective response rate documenting the best response was seen in 88.3% of patients with duration of response of more than or equal to 6 months in 62.2%. 3-year overall survival was 86.6%. Grade 3 adverse events were seen in 19% of patients, and there were 19 deaths total, out of which 12 were attributed to non-target disease progression in liver. So the study concluded that clinically meaningful response rates were seen with prolonged duration of response. Publication in JHEP, and it highlights the role of radiation segmentectomy. It is usually considered in patients for unsuitable for thermal ablation, where the tumor location is central near bile ducts, abutting diaphragm, gallbladder, or colon. In child A, good performance status, less than or 2 segments, adequate pulmonary function, no portal vein invasion, who are able to undergo angiography and catheterization, no extrahepatic disease, no uncontrolled, no uncorrectable GI blood flow. And if there is a lung shunting, it should result in a single dose of less than 30 Gray limit or a cumulative dose of less than 50 Gray to the lung. So this is RAD-SEG treatment, Y90 at ablative radiation absorbed dose to the perfused volume. The vasculature which covers the tumor is known as the angiosome. And here in this case, the tumor is treated with 1 to 2 centimeter margin, which is similar to what is done in surgery, where also 1 to 2 centimeter margin is taken around the surgery. And this margin also includes the microsatellites, which are usually present around the tumor, and they're also exposed to ablative dose. And rest of the hepatic function is minimally affected. This is one example listed in this publication, where the tumor is seen. The cone beam CT shows this perfusion by the radioisotope. And then this angiography shows cranial and caudal blood supply, and the after radiation segmentectomy, it shows complete response at 5-year follow-up. Related to ablation, resection, and transplantation has been compared with radiation segmentectomy, and it has been seen that in patients with solitary less than or equal to 3 centimeter tumors, the survival rates are almost similar between radiation segmentectomy, surgical resection, and RFA. And in case of solitary less than or equal to 5 centimeter, the 1-year survival ranging from 94 to 100%, with the 3 modalities, 3 years 69 to 89%, and 5 years 57 to 66%. Likewise, in case of patients with Milan criteria, single tumor less than or equal to 5 centimeter or less than or equal to 3 nodules, or less than or equal to 3 centimeter. The liver transplantation shows survival rates of 1 year 84 to 90%, 5 year 70s in 70s. Publication which highlights the dose distribution which is caused by the radioembolization. It shows that the different part of the tumor receives different doses, and it shows that in this case 20% of the tumor is receiving less than 50 gray, 13% 50 to 99 gray, and this color coding shows the less than 100 gray of dose going to this area. And this more than 150 gray to 9%, more than 200 10%, and more than 400 gray going to 9.4%. So in this case, we usually report the dose which goes to at least 95% of the volume, or the mean dose. And in this case, it was seen that this underdosing area resulted in relapse at follow-up. So it highlighted that the tumor area receiving less than 100 gray is at risk of relapse or residual disease on follow-up. Here in this case, similarly, the tumor, this is the dose volume histogram. It shows that the 95% of the volume is receiving about 400 gray, 70% receives up to 800 gray, and 50% of the volume receives doses like 1000 gray, and 30% 1400 gray. So there is a variation, and the different parts of the tumor receive different doses. In this case, this underdose area showed relapse on the follow-up. So this study, these examples were from this study, where prediction of recurrence of hepatocellular carcinoma following radiation segmentectomy with resin microspheres based on underdosed tumor volume on yttrium-90 PET-CT dosimetry. 40 patients were analyzed with tumor size of median 3.4 centimeter, ranging from 2.2 to 4.6 centimeter. It was seen that when a post-radiation segmentectomy Y90 PET-CT dosimetry helps in evaluating the treatment effectiveness and quantification of underdosed tumor, defined as the volume of tumor receiving less than 100 gray, that is V0 to 100. And it was seen from this study that a tumor of V0 to 100 of more than or equal to 28% volume has an increased likelihood of incomplete response. And the threshold analysis suggested that in achieving a tumor of at least dose to at least 50% of the volume should get more than or equal to 489 gray, or the volume receiving less than 100 gray should be less than 17%, which better predicts complete response at 6-month imaging follow-up. So the study concluded that when a post-air PET-CT dosimetry is done, it can guide decision on whether to go for an early retreatment instead of waiting at the 3-month follow-up imaging. Publication on resin microspheres, and it shows durable transarterial ablation of solitary hepatocellular carcinoma. It was seen that in the patients with complete response, the median tumor dose was 242 gray. Median angiosome dose, which was the vascular volume, was 112 gray. And it shows that it can yield radiation segmentectomy with larger numbers of lower radioactivity, can yield safe and durable HCC ablation. So in this case, similarly, this case was radioembolized and shows complete response on follow-up. The tumor recurred on inferomedial margin at 43 months of follow-up, which was treated with microwave ablation. And in explants, 6 out of the 20 patients had a durable complete response with complete pathological necrosis. And in those cases, the tumor median dose was 212 gray, and the median angiosome dose was 77 gray, and the percentage of group reaching stasis was 100%. This shows the dose is very confined in radiation segmentectomy and shows complete response on follow-up. Cases from our institute where a patient with 5.5 centimeter tumor was treated with TACE first and then had radioembolization, and this was the pre-therapy dose CT, which shows complete perfusion of the radioisotope, and then on after the complete therapy dose, it shows complete perfusion, complete tracer uptake, and at 3 months follow-up, there is complete necrosis with complete response. Histogram of the ILBS patient, and it shows that the liver, there was maximum dose of 2000 gray and a mean dose of 106 gray. And the normal liver received a very low dose of the normal liver minus the tumor volume. And the lung doses were also very minimal, mean dose of 0.6, less than 1 gray, and this is 2 gray. To put SBRT in context of TARE, here we see that in SBRT, the radiation source is X-rays, where photon is used, and it's an external radiotherapy modality. Here, a confluence is formed, and this patient, the color coding of dose color wash shows the red one is the 100% dose, which goes to the entire tumor, and some areas receive even more than 100%. Like the yellow one shows 110% of the dose, the pink one shows 115% of dose. And around the tumor, there is low dose spill. It is like 50% of dose, and we aim to decrease the 50% dose at 2 centimeter margin around the tumor. And the remaining liver also receives a very low dose, like 10 to 20% of the dose. But we maintain the mean dose of the remaining part of liver to the threshold. For a normal liver, that is 30 gray, and for cirrhotic liver, it is 28 gray. And this patient was treated with the combination of TACE, systemic therapy with sorafenib, and SBRT, and remains alive at 5 years and showed complete response. Here the dosimetry of SBRT shows the liver mean dose goes up to 11 gray and 1 to 19 gray. And we aim to cover 95% of the PTV volume with the 100% of the dose. And the mean dose varies, and the maximum dose also we document. So here in this study, radiation segmentectomy or ablative EBRT as initial treatment for solitary hepatocellular carcinoma were compared. Here in this case, solitary lesions less than or equal to 8 centimeter, no macrovascular invasion or extrahepatic disease were included. Radiation segmentectomy was aimed with a dose of more than or equal to 500 gray in 58 patients. External beam radiotherapy was given with photon or proton with a biologically effective dose of more than or equal to 80 gray with alpha beta of 10, and in 20 patients, this EBRT was used. Median age was more in EBRT group, median tumor size was more in the EBRT group, and worse performance status in the EBRT group, and all these were statistically significant. However, in the radiation segmentectomy group, there was more grade 3 fibrosis. Radiologic complete response was seen in 97% of radiation segmentectomy and 82% of EBRT group, and it was significant. The median time to radiologic response was 1 month in the RS group and 7 months in the EBRT group. 1 year local control was similar in the two groups, and liver transplant was performed in 48% versus 11%, with pathologic CR of 76% versus 33%. The 1 year PFS was comparable, and 1 and 2 year overall survival, 1 year was similar, and 2 year was 84% versus 59%. As most of these patients recur outside the targeted area, outside the liver or within the liver. This is our institutional study on SBRT in HCC, where 1 to 3 liver lesions in 46 patients, and portal vein thrombus was seen in 27 patients. And SBRT was used as a definitive, consolidative, or salvage treatment with a dose of 24 to 50 gray in 5 to 8 fractions with VMAT technique. And the median diameter was 7 centimeter, ranging from 1 to 16 centimeter. So it covered all stages of BCLC A, B, C, with new residual, progressive, or recurrent lesions. And systemic therapy was given in 35 patients. Shows serial changes in tumor markers at follow-up, and at 4 to 6 weeks, at 12 weeks, at 24 weeks, we see that median AFP was 196. It decreased to 92, 11, 12 on serial follow-ups, and in some cases it increased to 217, 207. And this can be because of either the regrowth in the treated lesion or elsewhere in the liver. And likewise, serum PIVKA2 decreased on follow-up or increased in some cases. Nearly 60% of the patients had decreased alpha-fetoprotein or PIVKA2 at 3 months after SBRT with systemic treatment. The overall survival and patient-reported relief in symptoms was seen in around 60% of patients after SBRT, which was mainly abdominal pain, discomfort, or fatigue. And the median overall survival was 21 months. The 6-month survival 84%, with 3-year overall survival of 28%. Grade 3 hepatic toxicity was noted during SBRT in 10% of patients. Liver dysfunction with Child-Pugh 2 or more points within 3 months after SBRT was noted in 27.3% of patients. Late GI toxicity was noted in 1 patient, which was managed conservatively, and the patient improved. Bleeding was controlled. And the study showed favorable disease control and prolongation of survival with combination of radiotherapy in early to advanced HCC. This was where the analysis of various factors for association with overall survival: ALB grade, Child-Pugh A versus B, portal vein thrombosis absent or present, and the response at 3 to 4 months after RT, both clinical and radiological response. It was noted that if the patient had an early response with complete or partial at 3 months, it was an independent factor associated with survival. Just to show one case which was treated with SBRT with portal vein tumor thrombus along with the liver lesion and had complete restoration of blood flow on follow-up. SBRT was given along with systemic therapy. And it shows that there is a difference in survival among patients with portal vein tumor thrombus and without portal vein tumor thrombus. A retrospective analysis of the immunogenic effects of intra-arterial locoregional therapies in hepatocellular carcinoma, and it gives a rationale for combining SIRT, that is TARE, along with immunotherapy. In this retrospective study, 3 groups of patients were compared. Resection, 32 patients, preoperative TACE, this was resection alone. In patients with resection along with preoperative TACE, 16. Preoperative SIRT in 12 patients. So it was seen that in the resected specimens, hepatectomy specimens, there was significant increase in tumor infiltrating lymphocytes, mainly CD4 T cells, CD8 T cells, and granzyme B expression in the SIRT group. So therefore, this study concluded that SIRT can be combined with immunotherapy for improving further outcomes in advanced cases and those and to prevent relapse in remaining liver. To summarize this talk on radiation segmentectomy, it provides durable disease control, prolonging survival, and the treatment decision on the modality to choose should be based on a multidisciplinary discussion based on individual patient characteristics.